So today, Rick Bedlack has graciously come. Now he's doing a whirlwind tour he's going to tell you about. He's been lecturing and he's starting a new program talking about ALS reversals. And can we understand them and make them happen more often? But first, a little bit about Rick. A lot about Rick. And I'm not even sure this is up to date. He may have some more titles by now. But Rick is Associate Professor of Medicine and Neurology at Duke. He directs the Duke ALS Clinic. He's Chief of Neurology at the Durham Veterans Affairs Medical Center. He's been recognized as a leader in teaching and in patient care, and education is his passion and advocacy. He started the Clinical Research Learning Institute, which we participated in, and now he's starting some new programs, and he's out there for patients. And that's why I love having Rick, because it's all about you. It's all about people living with ALS and people who care about people living with ALS. He's been chairman of the North American ALS Research Group, and he leads the International ALS Untangled program, which is a program that investigates different strategies for treatment that may or may not be valid. But when you go to a website and you read I Cured ALS with the ANA protocol, Rick will go out and investigate it, or chelation, and he has a group of us that join in those reviews to try to really assess it scientifically. So without further ado, Rick. Rick, it's really a pleasure to have you.
Thank you very much, Terry. It's always a pleasure to come to Philadelphia. As I've said many times, if I ever come down with ALS, I'm going to move here, and Terry and her team are going to take care of me. I honestly think this is the best ALS clinic in the world. The only thing I do worry about when I come here is that one of these days, Terry and I are going to be wearing the same outfit.
Let's come in black.
All right, so this is going to be a bit of a flyer for me. This is the first time I've talked about this new program I'm starting called ALS Reversals. And the title of this talk is, Can We Understand These and Make Them Happen More Often? So this is what I'm going to present to you today. First, we're going to just review the natural history of ALS. Then I'm going to give you some examples of something called ALS reversals. I'm going to try to convince you that these things are worth studying, show you how we're going to study them in terms of funding, how we're going to define them, what hypotheses we have for these, and what specific methods we're going to use to hopefully figure these out in the next few years. So let's just start by reviewing the natural history of ALS. Most of you in this room know all too well what this is like. So this disease is characterized by progressive disability and premature death. And we measure disability using something called an ALS Functional Rating Scale, or ALS-FRS-R. So this is a 12-item scale, and it asks questions about different parts of your body. If you've been in an ALS clinic, you've almost certainly completed one of these. For example, there'll be an item that asks you, how well do you speak? On a scale from 4 points, which is totally normal, all the way down to 0, which is you can't communicate at all. And there's specific cutoffs for achieving each number on each item of this scale. So 48 points would be totally normal, 0 would be no function at all. There's a lot of nice things about this scale. It's very easy to administer. It gives us a good comprehensive picture of the whole body. And in general, people with ALS change at about 1 point per month on this scale. Then there's survival. We also measure survival, and we use something called tracheostomy-free survival. And that's because once you've had a tracheostomy and been attached to a ventilator, you usually don't die from ALS. You die from something else like pneumonia. So tracheostomy-free survival. And on average, people with ALS live about 3 years from the time that they have a tracheostomy and get attached to a ventilator. Some of you may also know that there's a tremendous variability across patients with this disease. So if we look at the variability in progression as measured by the ALS-FRS, that's the graph on the left-hand side of this slide. Those are 30 different patients from the same clinic. Each of those lines represents the progress of the ALS-FRS scale over time, eventually dropping to 0 when the patient dies. You can see how different those slopes are. Some people are hardly changing over years, and some people are going straight downhill over just a few months. There's also tremendous variability in tracheostomy-free survival. So we talked about the fact that on average, people live about 3 years. Well, 20% of people live more than 5 years. 10% of people live more than 10 years. 5% of people live more than 20 years. Stephen Hawking, whom you may have heard about in the movie The Theory of Everything, he's had ALS for more than 50 years. So the variability is something that I think many of you probably have heard of. But I would venture to guess most of you have never seen anything quite like this before.
In 1985, Nelda Buss was diagnosed with ALS, amyotrophic lateral sclerosis, better known as Lou Gehrig's disease.
It was my birthday. I was 43 years old, and they told me I had Lou Gehrig's disease. Well, they actually said amyotrophic lateral sclerosis, and I still wasn't real sure what that was.
ALS is a medical mystery. There is no known cause and no known cure.
The established medical profession, they just said, goodbye, see you, have a good life, live it to your fullest.
The disease inevitably progresses from partial to complete paralysis of all the muscles in the body.
She just kept getting progressively worse, and I guess from the time she was diagnosed until she was basically an invalid was only about 6 months or something.
In the final stages of ALS, Nelda had become a quadriplegic, unable to move, but mentally alert and aware that she was about to die.
I gave away most of my good clothing that I had, and I had my dress all picked out for what I was to be buried in.
Then Nelda heard about Dean Kraft.
And it was just such a relief to talk to him. I said that the doctors say there's no hope, and he said, well, that's not always true.
Kraft did his laying on of hands for 3 months, and then they had a small but significant breakthrough.
In May, Glenn was showering me and I could move my toe, and that was so exciting.
After her toes, Nelda slowly regained movement in her fingers, then her back muscles. Soon she could control her hands, then her arms and her legs. Nelda worked very hard on her own physical exercise regimen, in addition to treatments from Dean Kraft. Her family videotaped her progress over the course of a year.
It's wonderful to see her and her family being together and enjoying life together. Words cannot express the feeling that one has when this happens.
Okay. How's that?
Everything has changed. She's back and she's doing more than she ever did before. I mean, it's great to have a mother. It really is.
So where did this video come from? Well, this was actually sent to me a few years ago by a patient with ALS. It came off the website for Dean Kraft, who advertises himself as the most documented energy healer of our time. So, as Terry mentioned, I've had now for several years an international program called ALS Untangled that investigates things like this. So this is actually a program that connects patients, doctors, and scientists through social networking. And we've got a very systematic approach to investigating claims that are made on the internet about therapies. So what we do is we put these things on a list. Somebody decides to take the lead on one of these things. We've got a whole step-by-step way that we go through it. We put together an article about it, and then we publish that article in a medical journal. There's now almost 2,000 people across the world that are following this program on Twitter. We've got almost 100 people like me that are linked together across 10 countries that are participating in these investigations. And we've got more than 150 things like this that we're trying to investigate. So when we see a case like this, the first thing that we do is we try to find the person. And the great thing about social networks like Facebook is you can find almost anybody now. So I found Nelda Buss and I explained who I was, and she sent me a giant box of her medical records. And as I looked through those records, I got the goosebumps. I said to my wife, you know how people already think I'm a little crazy because of the clothes and the hair? Wait till I stand up at the next international symposium and say that I found the cure for ALS and it's energy healing. Because I'm absolutely sure, reading those records, that Nelda Boos had ALS. In fact, she was seen by another great ALS clinic at the University of Virginia. I know the doctor that saw her. He's actually the editor of the major neuromuscular journal in our field called Muscle and Nerve. I know the person who did her EMG. He's one of the best EMGers in the country, so I know the EMG was accurate. This lady had the right story, she had the right exam, she had the right EMG, she had all the right testing for ALS mimics. So I'm sure she had the disease. I'm also sure that she progressed to the point where she was paralyzed. And finally, I'm sure that Nelda Boos is now, if not completely better, about 99% better. So what happened? Well, Nelda Boos is not the only ALS reversal that I've run into. In fact, since that case, I've been looking for them. And I've accumulated 15 others. So I have 15 files on my desk of people whose records I have that I am convinced had the right workup and have ALS and progressed and then significantly improved, which is not supposed to happen. Some of these people were even in clinical trials. So the graphs that you see there, those are graphs that are published from the neural stem trial. That's the trial where they're injecting embryonic stem cells into the spinal cords of people with ALS, as well as subjecting them to massive immunosuppression like we would do for organ transplants. And it may be hard to see, but there's one person in that trial, it's the purple line, who was progressing rapidly before they got the stem cells, and then completely turned around and regained a tremendous amount of function. So the question is always, what happened? But before we get there, it's probably worth asking the question, is it worth studying these people?
Yes, absolutely.
Well, look, this is not the way that we usually get our ideas about ALS or about ALS treatments, right? So usually what we try to do is make models of the disease. And the longest lasting model that we have is the SOD1 mouse model. It's a model that we make by inserting an abnormal gene into the animal, and the animal eventually develops a disease that looks kind of like ALS. And we've got a lot of variations. We've now got rats, and flies, and fish and worms that we can put the same abnormal gene in. So those are all different models of SOD1 ALS. We've even got newer models. We've got newer genes that we're starting to insert into animals, and we can even scrape the skin of people with sporadic ALS, put those cells in a dish, make those cells turn into motor neurons or cells that live much next to motor neurons, and try to figure out what's wrong with these cells from this person with sporadic ALS. The problem is, so far these models have not led us to a dramatically effective treatment for ALS. So we've been studying the SOD1 mouse now for 15 years, 20 years. And though we've learned a lot of interesting things, it's not led us to what we all want, which is a dramatically effective treatment. So is there any precedent for studying strange cases like the ones I told you about? It turns out that there is. So there are a group of people that we've known about for 20 years that get infected with the HIV virus and never get sick. They never take any medicine and they never get sick. They're called elite controllers. And for a long time, people just shrugged their shoulders and didn't know what to do with these folks. But recently, somebody put them all in the same database and used some of the powerful new genetic techniques that we have to look at all their genes, and they found something very interesting. Many of these elite controllers have the same genetic abnormality. It's a polymorphism in a gene called CCR5 delta 32. And what that genetic abnormality does is it changes the receptor in the surface of all cells that HIV needs to get in. So these people have a naturally occurring defense mechanism that makes them resistant to HIV. So by studying these people, we learned something that was fundamentally important about the biology of that disease that we didn't know before. Also, Pfizer took this information and developed a drug called Marivoc that blocks the CCR5 receptor that works for everybody with HIV. So there is a precedent for doing exactly what I told you about, studying strange cases of people who do unusually well with a terrible disease. So if we're going to study something, we need to have funding. We need to be able to define the thing. We need to have some ideas about why it happens, and then we've got to develop methods for working our way through those ideas. So funding. Well, traditionally, funding for research comes through grants. But I have found grants to be tougher and tougher to get. So first of all, most clinicians are getting squeezed to see more patients, generate more revenue for the people they work for, which means that there's less time to sit around and write grants. Also, most grants want pilot data, so it's kind of like a catch-22. How do I get the pilot data to get the money to study this thing? And then finally, even if you can find the time and get some pilot data, the percentage of grants that actually get funded is very small. Less than 1 in 5 grants that are submitted to the NIH get funded. So there is another potential source of funding, and that is patient donations. And so we've been in business in the Duke ALS Clinic for 15 years. We've never actually gone out and sought donations, but we've had spontaneous contributions to our clinic in the neighborhood of $3,000 to $5,000 a year since I started. And these have been used to fund a couple of very small pilot projects. So if I waited 10 or 15 years, I probably could get enough money from these donations to go ahead and study the ALS reversals. And then last year, everything changed. A cool new funding source became available through the Ice Bucket Challenges. So there's an interesting history to these. I won't spend too much time on this because it's controversial. I'm not sure anybody knows exactly how this whole thing started. But people have been dipping various parts of their body in buckets of ice and filming it and challenging others to do the same thing for many years. Really, I think ever since social networking started, people have been doing things like this. In fact, the first place I can find them, they were part of a drinking game called Neck Nomination. The first time I know of anybody doing this for charity was actually a Christian group who wanted to raise money for a mission to Liberia, and this was in early 2014. And after that, you started to see a lot of minor league athletes doing this for different charities. The first person that I know of that did an Ice Bucket Challenge and dedicated it to ALS was a semi-pro golfer named Chris Kennedy. He had a family member with ALS. He didn't have the disease himself. The first 2 patients that I know of that did the Ice Bucket Challenge were Pete Frates and Pat Quinn. And these guys, their social networks included prominent members of Boston sports teams and New York sports teams. And so shortly after they did it, several members of the New England Patriots, the Boston Red Sox, and the New York Giants did it. And you know, if Pete Frates and Pat Quinn had a few thousand followers on their social networks, those professional athletes had millions of followers. And so that's when it really exploded. The net result of all this is a tremendous increase in awareness of ALS. So there were 6 million unique YouTube videos related to Ice Bucket Challenges that were posted. And some of these, like for example, Bill Gates, had more than 20 million views each. So this was huge. If you want to know about the measurements of increased awareness, those graphs over there tell the story. The first graph talks about Google searches of the term ALS and the term motor neuron disease. So it's scaled so that it's a %-fold increase. What you can see that there's a 100-fold increase in Google searches for those terms last summer alone. Now, unfortunately, it's gone all the way back down to almost where it was, but for a while it exploded. The same thing with Wikipedia searches. So on average, people search for ALS on Wikipedia about 2,000 times a day. And at the height of the Ice Bucket Challenge, it was almost 500,000 times per day that people were searching it. So a tremendous amount of awareness. And then, of course, back to the topic of conversation of this talk, there was a tremendous amount of money generated from this. So overall, the figure now stands at more than $220 million were raised last summer as a result of these ice bucket challenges. So there's a lot of resources for us to do new things. And some of this actually came to our clinic. We had patients from our clinic that went out and did ice bucket challenges, and one family in particular, and they actually raised $328,000 for our clinic last year. So now we've got the money to study ALS reversals. So if you're going to study something, you also have to figure out how to define it. And we can all kind of have an idea in our minds of what an ALS reversal is, but if you want to study something, you've actually got to have an operational definition, something you can put on paper that everybody can follow, that everybody can replicate if they decide to study these things. And so no one in history that I know of has ever studied ALS reversals before, so there's no starting point here. So we decided to try to figure this out by going into the largest existing database of patient information, which is called PROACT. So PROACT is comprised of 17 previously published clinical trials. All the patients in all those trials that were in both the drug-treated and placebo group, they all agreed to have their data dumped into this big database when it was over. So you have literally many thousands of patients with longitudinal information, including those ALS, FRS, R scores that we mentioned in the beginning. So the first thing I did is I asked my colleagues at Mass General Hospital to look in this database, to look at an interval of 165 days and an interval of 180 days, and tell me what percentage of people are getting better in terms of their ALS, FRS scores for an interval that long. And it turns out it's much higher than I would have expected. About 20% of people with ALS in the database have some period during their disease where they get better for 5 or 6 months. Very interesting. Now let's look a little bit more closely at the things that analysis was picking up. So these are ALS, FRS, R curves from 2 individual patients in the database. And the area of the curve that gets fatter, that's what this analysis was picking up as an ALS reversal. So some of these reversals are clearly a lot more interesting than others. If you look at patient B, the area that was picked up as an ALS reversal really consists of one data point that was much different than the point before. And after that, that patient continues to decline and deteriorate just like they were before. That may not be all that interesting. That may have been a measurement error. Maybe there was a different person in clinic that day doing the measurement. Or maybe that person got a medication that helped one item on the scale. Like, for example, there's an item related to drooling. And if you're constantly drooling and carrying a towel around with you, you'd be a 0. And if we gave you something like a scopolamine patch or some amitriptyline and your drooling went away, you'd pick up 4 points on just one visit. So that's not all that interesting. But look at that other patient, patient A. That's very interesting because for the course of a year, they slowly and steadily improved. They were 1 or 2 points better at every visit. So that looks like something that might be biologically important. So I next contacted a group in Cambridge, Massachusetts called Patients Like Me. And I asked them to help me figure out, help me find these more robust reversals. So they did a little bit of a different analysis. They constructed a graph of the percentage of patients with different size changes in their ALS, FRS, lasting different amounts of time. And as you can imagine, as you go further and further along in this database, there's less and less patients to look at. Many of these trials only lasted 6 months or 12 months. Very few of them lasted longer than that. So at the beginning of this analysis, we had over 1,000 people to look at, and by the end, we had about 500 people to look at. Still a pretty good number. In the bottom right-hand corner, you see the Patients Like Me analysis. And so the blue trace is a 0-point change in the ALS-FRS. So it's the percentage of people who had that amount of change lasting different amounts of time. So if you look over a very short interval, just a few months, lots of people don't change by 0 points. But if you go all the way out to a year, that number becomes very small, less than 10%. The green line is a 1-point improvement. The red line is a 2-point improvement, the blue line is a 3-point improvement, and the purple line is a 4-point improvement. So what we can conclude from this is that very small, transient ALS reversals are quite common, but large, long-lasting reversals are not. And so if we're going to use that information to construct a definition, we really want to focus on the large, long-lasting ones, because those are the ones that we think might be biologically meaningful. And this is what we decided to do. We decided to define this ALS reversal as a person that's got an improvement of at least 4 points on the ALS-FRS scale that lasts at least a year. And if we do it that way, it's about 1% of people with ALS that have that. And guess what? That's the same percentage of people who get HIV that are elite controllers. So that's a good thing, because they were able to figure out what was going on in those people with a small number. Maybe we can do the same thing. So what specific things might be going on here in these ALS reversals? Well, first of all, we have to consider the possibility that the diagnosis was wrong. So we don't have a test that comes back positive or negative for ALS. We diagnose this disease based on a history of progressive painless weakness, an exam showing upper and lower motor neuron signs, an EMG showing widespread lower motor neuron disease, and a number of tests to rule out mimickers. It is possible that there could be mimickers out there that we don't know about. So I can't say with 100% certainty that these 15 ALS reversals that I know about had ALS. What I can say is that they had ALS by everything I know of. We just don't have the test yet to be 100% sure. Second possibility, which is more exciting, is that maybe these folks are like the elite controllers. Maybe they've got something different about them that allows their body to beat the disease. And if we could figure out what that was, maybe we could give it to everybody. And then the third is, maybe these folks have actually found a treatment, however odd, that really does work. And so I've now constructed 2 separate programs at Duke to explore these hypotheses. The first program is called STAR, the study of ALS reversals. And the second program is called ROAR, the replication of ALS reversals. And I'm going to tell you about the second program first. So in ROAR, what we're going to do is a series of small pilot studies using exactly what some of these patients were using when they got better in more patients to see if we can make anyone else better. Okay? So what are the options as far as those treatments? Well, of these 15 people on my desk, there were 5 different treatments that they used. One was energy healing. You saw the video of the patient who did that. One was a compound called Lunasin, sold by a company called Relive. One was autologous mesenchymal stem cells taken from a person's bone marrow and put back into the same person, into their spinal fluid and muscle, through a company called Brainstorm. One was embryonic stem cells, as I told you about, through neural stem, injected into the spinal cord. And the last one was a drug called AimsPro, also known as hyperimmune goat serum, which is owned by a company called Deval. So of these 5 things, we can't study energy healing. I tried to study it, but Dean Kraft refused to be studied, and Dean Kraft has now died. So that's off the board. We're not going to be able to study either one of the stem cell protocols because the companies themselves are taking those forward and doing their own studies. And we're not going to be able to study AimsPro, again, because the company is doing their own studies. So that only leaves us with one, Lunasin. So what is this stuff? Well, it's a small peptide that's isolated from soybeans, and the company says it has an epigenetic mechanism. What does that mean? What this actually does is it alters the pattern of histone acetylation in a person. So histones regulate the particular pattern of genes that are turned on. And one of the things that we've known for a long time is that the pattern of histone acetylation in people with ALS is abnormal, as is the pattern of genes that are turned on. There is a destructive pattern of genes turned on instead of a protective pattern, which is very odd. And we've gone after histone acetylation before in a mainstream ALS trial with a drug called sodium phenylbutyrate. Didn't work, but maybe this has a different effect that will be more powerful. What's the evidence that this might work? Well, I have found one definite ALS reversal. Man's name was Mike McDuff. I won't show you the video, but it was another situation where late at night I got a video from a patient that had been on that evening. It was from Providence, Rhode Island, and it showed a patient who said they had ALS and said that as of a year ago, they were not able to speak or swallow and had lost most of the use of their arms and legs. Then they started taking Lunasen, and now their speech had returned to normal, and their swallowing had returned to normal, and they had their feeding tube taken out, and the strength in their arms and legs was getting better. So again, I found Mike McDuff on the internet. I got him to send me records, and he's right. He was seen at Mass General Hospital by 2 neurologists I trust, as well as at the University of Rhode Island. Mike McDuff actually has a pure lower motor neuron form of ALS, which is called PMA. But he has had a reasonable workup for mimics, and he is followed in an ALS clinic. So I am certain that he's getting better because I have measurements from his speech therapist, his nutrition therapist, his physical therapist, and his occupational therapist to tell me he really is getting better. Now, he's not the only one that reports benefit on Lunasen. So since I became interested in this, I've been bombarded with emails from people around the world who are trying Lunasen. And there are 13 people who've supplied me with enough information that I can at least make a table. I don't have records on any of these folks. I've asked for them but not received them. And so it appears that the majority of these people are also reporting gains in function, which would be unexpected in ALS. But again, I have not been able to validate these. Some good things about Lunasen: it appears to be very safe and well tolerated. One bad thing about it: to take it the way Mike McDuff took it would cost about $700 a month. So it's quite expensive. Now, the Relive Corporation has graciously agreed to supply us with free product for our trial. So we won't have to charge people anything to be in our trial. So, I mean, let's be honest, it's a long shot that this ROAR program is going to be able to find something that reverses ALS. So to make sure that it's useful in some way, we're going to build something else into this. And that is, we are going to try to incorporate some very novel, patient-centric design features to try and boost enrollment and retention in clinical trials. And we're going to test these design features as well as testing the Lunasen. So it may surprise you to see this slide that talks about the problems that we have with enrollment and retention in our clinical trials. But this really is one of the reasons that it's been such a slow process to try to find treatments for ALS. Less than 5% of people with ALS are getting into clinical trials. Even at busy centers like Terry's and mine, the average, historical average, is that about 2 patients per site per month enter a clinical trial. And most of us are seeing 80 to 100 patients in an average month. So it's a very small percentage. Also, people don't stay in clinical trials. About 25% of people drop out before the trial's over. Now, we spent a lot of years studying this. We think we have some ideas about why it's happening. First of all, traditional clinical trials have very narrow inclusion criteria. Has anybody here tried to get into a clinical trial but couldn't because of how far along they were in their ALS? Does that happen to anybody? It's a few people. It's a very common complaint that I get when I travel around, is that the trials are too exclusive. Why do we do that? Because most trials are looking for a very tiny signal. They're looking for a 10% slowing in the decline of the ALS-FRS. That's a tiny signal in a very noisy disease. And so when you try to find a small signal in a noisy disease, you got to homogenize people as much as you can in the beginning of the study to try to reduce your noise. Some other reasons why we think we don't enroll very well. Well, first of all, there's some doctors that don't ask their patients to get into research. Also, we understand that there are some patient factors. We understand that traditional trials are very burdensome. Asking you to come to our clinic every week or every month for a year and spend several hours getting poked and prodded is a lot. We understand that sometimes patients don't want to take a chance of getting a placebo And also there's a lot of frustration among patients about how long it takes to get an answer. You know, in a disease where people live on average 3 years, it takes sometimes 2 years to do a trial and another 6 months to get the results out. That's too long. As far as retention, very similar themes there. We think people are dropping out mainly because of burdens and to some extent because of adverse events that they encounter during the study. So we have some control over these things, right? So I know Terry and I, and many of my colleagues, they do go and ask patients to be in research. So that's not a problem in a lot of our clinics. But the inclusion criteria, we have some control over that. The burdens, the placebo, how long the studies take, we have some control over all that, right? So what we're going to do in ROAR, I don't think has ever been done before. We're going to design studies that are wide open as far as who can come in. Now how can we do that? Because we're looking for the biggest signal anyone's ever looked for. We're actually looking for people to get better. We're not looking for a slight slowing in disease progression. We are looking to see if people actually improve over time, which has never been looked for before. We will miss a small signal with this design. If this program doesn't find anything, it's quite possible that Lunasyn might have slightly slowed ALS. We'll miss it. We're not going to have a placebo control in these studies. We're going to use historical controls. So we're going to match everybody that comes in to a historical control from a big database on patients like me. We're not going to have very many visits required. We're actually going to teach people to enter their own data on a website. And most of the visits from this study you'll be doing yourself from your own computer in your home. And then finally, you won't have to wait to find out what this study shows. The results of this study will be available to everybody in real time. Anybody at any point in the course of this will be able to sign on to a website and see exactly what's happening to everyone in the study. And how are we going to do all that? By partnering with this group, Patients Like Me. Has anybody heard of Patients Like Me out here? Is anybody on it? Good, good, good. So it's an amazing website. It's kind of like Facebook for people with rare diseases, but it takes it one step further. So not only can you create a profile about yourself, which is over on the left-hand side of this slide, telling us who you are, where you live, how old you are, what disease you have, what your disease looks like at this particular time, but you can also do things called treatment evaluations. So if you're experimenting on yourself, you can go on there and you can actually tell us what exactly you're taking. You can get your ALS functional rating scale scores from your clinic, even your forced vital capacity and your weight. You can put in a score for whether you think the treatment is helping you. You can tell us about any side effects that you might be encountering, and you can also tell us how burdensome you think the treatment is. Right now there are 7,000 people with ALS registered on Patients Like Me, which is pretty extraordinary when you consider the fact that the National ALS Registry says there's only 12,000 people with ALS in the whole country. It means the majority of people with ALS, since most folks are American on that, most of these folks in the United States, more than half are on Patients Like Me. There's a lot of amazing things that you can do with Patients Like Me. As a clinician who's interested in alternative therapies, I can actually go on there and pick a therapy and see what's happening to patients on Patients Like Me who are trying that. So for example, if I looked at coconut oil, I can see that there's 25 people on Patients Like Me that are taking it. I can see that there's 12 people that have filled out evaluations, and I can see what those people think in terms of whether it's helping them, what kind of side effects, how difficult it is to treat. The other thing that's relatively new is that you can actually do research on Patients Like Me. So they've developed a way to create a matched historical control, and it has to do with the slope of the ALS-FRS before any treatments have been tried. And using this matching algorithm, they were actually able to show that people on Patients Like Me that were taking lithium were no different than matched controls that were not taking lithium. And it actually took the scientific community a few years, 5 clinical trials, to come up with the same conclusion. I'm not saying that this is always going to predict what happens in a clinical trial, but it is a very interesting way to do a pilot trial. So we've got some specific hypotheses that we're going to test in this ROAR lunasin study. The first one is that this lunasin-containing supplement regimen can reverse ALS. The second one is that it can at least decrease the rate of progression of ALS by 50%. The third one is that we can teach people to accurately measure their own ALS-FRS and record it on the website Patients Like Me. The third is we can teach people how to record a very careful weight even as they become more disabled throughout the course of the disease, and that this will be accurate. The fourth one is that the novel features of this trial are going to be associated with a much higher enrollment rate and a much lower dropout rate than traditional studies. So this, again, is widely inclusive. It's open label. It's a pilot trial using historical controls. We're going to start bringing 50 patients into this trial probably next month. As you can see, there's not many inclusion or exclusion criteria. There are no disease duration criteria. Even a person far advanced with a tracheostomy on a ventilator who's quadriplegic can be in this study. Why? Because I think they can get better. So they can be in. Only 3 face-to-face visits over 12 months. The other visits will be done on your home computer. And you'll be called by our coordinator in the beginning to coach you through the process. And also you'll be prompted if you don't enter anything on the website for over a month. So let me just spend the last part of this telling you about the second half of the ALS Reversals program, which is called STAR. So this is where we try to understand what's happening in these patients that we know about. And again, there's 2 possibilities other than the treatment. One is that the diagnosis was wrong, and the second is that these people have something special about them that allows them to beat the disease. So let's take the first one. If you look in any textbook of neurology, you'll see a long list of ALS mimickers. And these fall into categories: genetic mimickers, toxic metabolic mimickers, infectious mimickers, inflammatory mimickers, structural mimickers, and miscellaneous mimickers. We can argue about some of these, but the thing that's important for this talk is which of those mimickers could actually produce something that looks like ALS, but spontaneously gets better. I can only think of one category, and that's the antibody-mediated diseases. Antibody-mediated diseases naturally fluctuate. A structural lesion like spinal stenosis or a brain tumor is not spontaneously going to get better. So antibodies are easy to measure. There's a lot of different ones that we know of that can produce weakness that, at least superficially, can look a little bit like ALS. Classically, the motor neuropathy antibodies are the ones that we worry about, things like GM1, MAG, ganglioside antibody. It's well recognized that these can produce a disease that looks like the lower motor neuron form of ALS, progressive muscular atrophy, but there actually is one case out there where a person had both upper and lower motor neuron signs and had one of these antibodies and was treated with immunosuppression and got completely well. So it is possible that these antibodies might be able to produce something that looks just like ALS. There's other antibodies. There have been a couple of recent reports about celiac antibodies producing a disease that looks just like ALS. Paraneoplastic antibodies producing something that looks like ALS. And then this one's my own personal favorite. And this is myasthenia gravis antibodies. Myasthenia gravis is a different disease. It's a disease where the body makes antibodies against muscle, and people develop a characteristic pattern of droopy eyelids and slurred speech. It usually fluctuates. It's worse later in the day. And it can look kind of superficially like ALS. There's a whole bunch of different antibodies that can produce myasthenia gravis. Most of them are acetylcholine receptor, or antibodies that bind to things right next to that receptor, for example, MuSK. But there's a brand new antibody that's called LRP4. It's just reported that I know of in the past year. And it turns out that a study at the American Academy of Neurology last month showed that about, in one population anyway, about 20% of people with what looked like ALS had LRP4 antibodies. So is it possible that there's a subset of people with ALS who actually have an odd form of myasthenia gravis caused by LRP4? And if so, if we could find them, we might be able to treat them with immunosuppression and make them better. So the methods, I'm going to try to get a lot more of these ALS reversals, and so within the next few months I'll be sending a survey out to my colleagues asking if they've ever seen one of these, and if so, could they ask for permission to send me the records? Could they send me some blood on the patient so that I could actually do antibody testing? And that whole list of antibodies that you see there is what I want to check. More exciting than an ALS mimic would be the possibility that these patients, their bodies have figured out a way to beat this disease, just like the HIV elite controllers. So how would that work? Well, the biology of ALS is very complicated. There's a lot of steps. And so this diagram is even a few years old, but it's the most recent one I can find. So among the many things that are going wrong in a person with ALS, there's protein aggregation, there's genetic dysregulation, there's problems with the mitochondria, which are the power plants, there's problems with transport up and down the microtubules in the cell, so things can't get from one side to the other like they're supposed to. There's problems outside the motor neuron. Astrocytes are not sucking up toxic chemicals like they're supposed to. A cell called the microglia, instead of being in a protective state, it's actually in a destructive state, so it's trying to kill the motor neuron. And then there's a cell called the oligodendroglia, which is not supplying energy to the motor neuron like it should be. A whole bunch of things going wrong. So it's possible that these ALS reversals have a polymorphism that affects one of those pathways that actually stops it from killing the cell. Is there any precedent for that? Well, there are 2 genes where we have found polymorphisms that affect progression. One's called KIFAP3 and the other's called FA4. So there's a subset of people with ALS who have polymorphisms in those genes that progress much more slowly than the average person with ALS. So maybe there's another subset that has a polymorphism that stops one of those pathways. Now, stopping the disease is not what we're talking about. We're talking about people getting better. So if you stopped one of those pathways, how would a person get better? Well, there's a precedent for that too. Most of you have heard of polio. So in poliomyelitis, the disease, the virus, kills a whole bunch of motor neurons and the person gets very weak. If they survive, very often they get much stronger over many years. How does that happen? You don't make new motor neurons. What happens is that the motor neurons that you still have alive, they send off branches. And so they now innervate a bigger place in the muscle. It's called collateral sprouting. So I have no doubt that if we could stop what was happening in ALS, people could get stronger, the body could regenerate. So what we're going to do in this part of STAR is get another blood sample on these folks and do whole exome sequencing. So that's a way of looking at the business end of all the genes that a person has to see if anything's different about these people compared to people with run-of-the-mill ALS. So I'm just going to summarize with a quote here by Tom Robbins that I think equally applies to these ALS reversals as it does to me. There's no such thing as a weird human being. It's just that some people require more understanding than others. So these ALS reversals, I think, might provide clues to ALS mimics, mechanisms that people's bodies have figured out to beat the disease, or even unusual new treatments. We now have secured funding. We've got a way to define ALS reversals. We've got specific testable hypotheses, and we've developed methods for working our way through these hypotheses. And we hope that the first study, which will be the Rohr-Lunasyn study, will be opening in the next month or 2. So if you want more information, if you want to follow us along and see when these things open, the best website to follow would be alsreversals.com or .org. But I do have other websites for ALS Untangled and for my clinic. And finally, I just want to say thanks, first and foremost, to all the patients and families with ALS. You're our inspiration. You participate in our studies, and now you're even funding our studies. So we literally could not do this without you. I also want to thank one particular family, that's the Larry Vance Hughes Foundation, who supplied the bulk of that $328,000 that's going to let us get this project off the ground. And then my colleagues in Massachusetts at Mass General Hospital, as well as patients like me. And finally, my Duke ALS team. I'll be happy to take any questions.